you are going to for that on your screen. So you can go ahead and click your options once that pops up. And so just to cover a few housekeeping items right now, we'd like to ask everyone to update their Zoom names and to include their organization so that way we can create a really fun and collaborative environment and know exactly which organizations we're representing today. And to break the ice, please feel more than free to share 3 words that describe how you all are feeling today in the chat. Just to let you know, all participants are going to be on mute. However, we will definitely encourage you to use the Zoom Q&A function for any questions that you may have. Based upon how the conversation goes, we would love to make sure that we touch point on some of those questions during the presentation. But if there's anything that we don't touch base on during the conversation, we'll definitely get to it towards the end of the session where we've created some time for Q&A. And lastly, I'd like to remind everyone to stay on mute so that way we can make sure we have a nice, clean facilitation and can hear nice and clearly. All right, so I would like to extend a very special thank you to our project partners who are also on the call today. CalAIM Links is a collaboration of Transform Health, Aurrera Health Group, and HealthBegins, and we're being generously funded by the California Healthcare Foundation. To learn more about any of our partners, a link is going to be provided in the chat right now, so that way you can click on this hyperlink to have a copy of today's presentation, and you can also learn more about our organizations. And I'm also so excited to let everyone know that we do have Carlina Hansen from the California Healthcare Foundation on the line with us today. And Carlina has invested an incredible amount of wealth and resources into making this project possible. Thank you so much, Carlina. Please feel more than free to introduce yourself to the audience.
Thank you so much, Alexis. Greetings, everybody. I want to thank you so much for joining us today. I thought as we kicked off the session, I would share a little bit about the California Healthcare Foundation and why we're funding this important work. We know that 1 in 3 Californians lives in or near poverty, and because Californians with low incomes face the biggest health burden and the greatest barriers to care, our priority at the foundation is to make sure that they have access to high quality care. We also know that income is not the only factor that limits access to healthcare in California. Too many Californians face structural barriers to care based on the color of their skin, their ethnic background, or the language they speak. For this reason, health equity is the primary lens through which we focus our work at the foundation. As I think we all know, Medi-Cal is the predominant system of care for people with low incomes and many people of color in California. As Medi-Cal seeks to reach people in new and innovative ways, it involves forging new kinds of partnerships, ones that rely on community-based organizations that are deeply connected to the people that we seek to serve. These CBOs not only offer new services like those that are articulated in CalAIM, but they offer new perspectives and can provide an important cultural bridge between our healthcare systems and California's diverse communities. So we hope that by way of this project, CalAIM Links, we can strengthen the connections between Medi-Cal managed care plans and these community-based organizations. And we feel that this is an important part of the puzzle that can help us realize better health for all Californians. And finally, before I pass it back to the fabulous team, I want to express my deepest gratitude to HealthBegins, Aurrera Health, and Transform Health. Their vision and commitment to health equity have really made this work possible. We've been collaborating now for several years, and I really deeply appreciate their partnership. I also want to thank all of you who are attending today for the work that you do to improve the health of Californians. With that, I will pass it back to you, Alexis.
Thank you so incredibly much, Carlina. And once again, to just reemphasize, we definitely appreciate all that you've invested into carrying us through to this moment and, being able to host this session today. So once again, just thank you so incredibly much. And so before we dive into today's session, I would love to provide our audience with just a little bit of background on what led us up to this day. And so at a high level, we all know that CalAIM is working to transform Medi-Cal by providing a more equitable and coordinated approach to providing services. And this approach provides us with an opportunity for CBOs and MCPs to work together. However, one thing that we realize is that smaller CBOs, particularly those that are BIPIC plus led or serving, or those that employ a community-based workforce, they're going to encounter challenges when it comes to seeking out those contracts with plans because they don't exactly have those pre-existing relationships, and the current infrastructure and landscape isn't exactly set up to advance that partnership development. And so because we understand that strong equity-oriented partnerships between CBOs and the plans are critical to fulfilling the promises of CalAIM, CHCF funded our work to design an intervention to advance those relationships, and that's what brings us here today. And so just to briefly touch point on what we were able to accomplish in the last phase of work, we hosted 9 technical assistance sessions, and those sessions, as described, focused on improving CBO contracting readiness and advancing their relationships with MCPs. 2 of those sessions were statewide sessions, just as the one we're hosting today, and the remainder were hosted in 4 specific counties. Those counties were San Joaquin, Stanislaus, Shasta, and Sonoma. We worked with 3 health plans to design the content and answer questions that CBOs had about contracting requirements. And those plans are also on the line with us today. That includes Partnership Health Plan, HealthNet, and the Health Plan of San Joaquin. And I definitely do not want to overlook just how much those plans invested into making those sessions possible and how much they contributed to the current phase of work and making sure that CBOs have the tools and resources they need to be successful and move towards contracting readiness. And in summation of that work, we had approximately 769 participants join those sessions, and the response was incredibly positive, hence why we're able to move forward with continuing that work today. And if you want more information on what we performed and how we implemented the last phase of work, feel more than free to visit healthbegins.org/CalAIM. Everyone should have received a wonderful email that included that hyperlink. And so we have a pre-recorded information session that breaks down exactly what we did during the last phase of work. And so before I pass it over to our amazing facilitators and are going to move into our objectives for the day, I just wanted to briefly share what our project goals are. So taking the lessons learned from the previous sessions and with continued support from the California Healthcare Foundation, we've designed a continuation of our program offerings for 2022. And so primarily, we're seeking to recruit CBOs that are led by and serve people from communities that have been historically marginalized by societal policies. And we're going to focus on identifying their needs, building knowledge, and elevating barriers to providing community support services. Second, we want to make sure that we're strengthening statewide capacity among community-based organizations for those CalAIM community support services. And then lastly, we want to make sure that we're building impactful relationships, not just with between CBOs and the plans, but with CBOs and intermediaries, CBOs and other contracting entities. We want to make sure that we're fostering networking and community building so that way we can have a very successful outcome that lasts for the long run. And now moving into our amazing partners in this project and in this work, I wanted to introduce Lucy Pagel and Jill Donnelly from Aurrera Health Group. Lucy's going to talk us through the essential components of Medi-Cal and managed care and how CalAIM and community supports specifically aims to reform this system through a whole person care approach. And with that being said, Lucy, thank you so incredibly much. We are definitely excited to dive into today's objectives and our agenda.
Thank you, Alexis. Excited to talk to you all today. So we know members of our audience today are coming from all sorts of backgrounds and CBOs across the state with various levels of exposure to managed care and Medi-Cal and CalAIM and community supports. So we really wanted to take the opportunity on our first session of our 3-session series today to take a step back and really think about the delivery system through which CalAIM and specifically community supports are seeking to make change. So this session is going to provide that foundational information on Medi-Cal managed care. I'm going to touch on CalAIM as a whole, and then we're going to really drill down later on into community supports and touch lightly on the pathways for providers to begin contracting with managed care plans if you haven't done so already. But all of that will grow as our sessions move through the rest of the year. Next slide, please. So agenda, I kind of already went through this. I think we can go to the next slide. All right. So to dive into Medi-Cal and managed care as the foundation for CalAIM. To start, we just want to open up with a poll, get everybody interested and excited. Can you share on the poll how familiar you are with Medi-Cal? And by familiar, we don't mean, Medi-Cal is a health system, but what, how does billing go through Medi-Cal? All those questions. How familiar are you with the financial aspects of Medi-Cal, the delivery system is what we're looking to find out today.
And Lucy, we have a lot of responses coming in right now. And so I'll give it about 10 more seconds and then we can go ahead and share those results.
As long as we need to have them trickle in, Alexis, I'll defer to you. All right. Great. It looks like about a little less than half are very familiar, but we do have a large contingent that is not very familiar or somewhat familiar with Medi-Cal. So for those very familiar, hold on tight. It's just a few slides before we dive into CalAIM. And for those who are not too familiar, hopefully this will help. Next slide, please. So Medi-Cal is California's Medicaid program. It's a public insurance program that provides healthcare for so many Californians. I think at last count about 14 million, which is about 1/3 of the state, who meet the requirements for Medi-Cal. And these are individuals who are often low income. And most beneficiaries receive Medi-Cal services, so all their healthcare services at no cost. Next slide. Medi-Cal covers such a wide range of services. I'm not going to read off the slide, but you can see the bullet points here. The services range from substance use disorder services, long-term care, preventative care, ambulatory care, really everything folks need. And as we'll touch on later, what CalAIM and specifically community supports do is build off this list of services to really address the whole person more than Medi-Cal ever has done before, and more than Medicaid does in general. As California's Medicaid program, Medi-Cal is extremely innovative. And I will say states across the nation look to California's Medi-Cal program to see how it's innovating on the traditionally offered services. Next slide, please. So the majority of services provided through the Medi-Cal program are provided under a managed care model. Under this model, the state, which is the Department of Healthcare Services, DHCS, will contract with managed care plans to provide Medi-Cal services through a capitated payment model, which means that the plans receive a specified dollar amount from the state per member per month. And then what the health plan does with that money is build out a defined network of providers to deliver the services. And it's the health plan that pays their network directly, kind of coming out of that per member per month capitated rate they get from the state. So all counties in the state have managed care plans. Managed care plans are the ones who are running community sports and enhanced care management. But, some counties will have one managed care plan and some, one or two have 5 to 7 managed care plans. So the model of the managed care system differs by county. If you're curious who your managed care plans are in your county, this is a great link you can go to figure that out. So I'll pause there. That was just the absolute briefest of background on managed care and Medi-Cal to see if there are any questions before we dive into CalAIM and how it aims to kind of disrupt the system and make it more whole person focused. Right. Not seeing any questions right away, but as they come up, we're happy to answer them. I will now pass off to my colleague, Jill Donnelly, who's going to walk us through CalAIM as a big picture and then drill down through community supports.
Great, thanks, Lucy. All right, I love talking about CalAIM, so I'm really thrilled to be here with you today to talk through a small piece of it. So we can go to the next slide. CalAIM is short for the California Advancing and Innovating Medi-Cal. It is a multi-year initiative led by DHCS. It launched in 2022 and will continue rolling out through 2027. So it is a long process to get CalAIM implemented. The initiative implements delivery system and payment system reforms across the entire range of Medi-Cal programs and services. It's designed to improve quality of life and health outcomes of Medi-Cal beneficiaries. And the thing that really sort of distinguishes it is that it's really looking to take a person-centered approach that targets social determinants of health and reduce health disparities and inequities. So really ambitious policy. Next slide. CalAIM's goals. So big takeaway here, CalAIM is composed of major delivery system and payment reforms, quality of life and health outcome improvements, all of which are delivered through a lens of a person-centered approach. So really taking into account the whole person and all of the factors that impact their well-being. Next slide. So we're going to talk a bit about community supports in particular, but we wanted to give you just a look at the number of initiatives under CalAIM, and this doesn't even scratch the surface. There are probably 60, but these are some of the big buckets of initiatives that are coming down the pike. You can go to the next slide. So again, another look at some of the initiatives. Again, under each of these categories, there are many, many initiatives. We're going to start kind of zooming in here. So we're going to talk about population health, but it is important, especially for those of you on the phone who are involved in counties, either as a contractor or if you're part of the county entity. There are a lot of other initiatives that really impact those entities. Next slide. So this is a terrible slide that I designed, but it has too much information on it. But the important thing here is that first category, which says enhanced care management and community supports. These are the first elements of the state's population health management program initiatives to launch. But population health management is the cornerstone of CalAIM. It is a huge implementation under population health management initiative. There's also a population health management program, which is managed care driven, and a population health management service, which is a huge technological solution that will take in data from very disparate sources across the state that will live at DHCS. There's NCQA accreditation. So very major initiative. Population health management goes live, starts to go live January of next year, but enhanced care management and community supports are already live in many counties. There is a phased approach there as well, but we're just going to focus a bit on those programs today. Next slide. So again, let's talk about zooming in, community supports, a really wonderful part of CalAIM. So community supports are medically appropriate, cost-effective services that managed care plans can offer in lieu of traditional Medi-Cal benefits. You may have heard them referred to as ILOS. They've been renamed, but they are meant to offset traditional services provided under Medi-Cal. They're there to address medical and social needs to help beneficiaries avoid higher level care. And again, in lieu of higher cost services like skilled nursing admissions, ED admissions, et cetera. They are not Medi-Cal benefits. And interestingly enough, they are optional for managed care plans to offer and for members to accept. Next slide. So many of you may have participated in California's Whole Person Care Pilots or the Health Homes program. Both initiatives existed prior to CalAIM in various counties across the state. They are now both complete and have transitioned into enhanced care management and community supports. Both of those programs are really built on the learnings from whole person care and health homes. And one thing I want to mention is that California's Community Supports Initiative is really innovative and is receiving lots of national attention for some of those innovations. So it's one of those things that, as Lucy mentioned, a lot of states are looking to see how it goes in California and what the outcomes are. One other thing we'll mention is I mentioned that community supports are optional for the managed care plans to provide, but managed care plans are encouraged to contract with local entities, including community-based organizations and counties, to provide community supports. Next slide. We're not going to read all of these, but these are the 14 community supports that managed care plans can offer. They are also allowed to submit proposals to offer additional community supports that aren't on this menu, but those are subject to DHCS approval. All of these that are listed here have been approved. I will call out that on this list, you'll see housing and tenancy supports, recuperative care and respite services, nursing transition services, supportive food programs, home modifications. There are a lot of different populations that the state is trying to get services to through this program, including those experiencing homelessness, aging populations, and many others, those experiencing disabilities. So I think we have a poll. Is that right? Yes. All right. So a little quiz for all of you. Who can be a community supports provider? We've got a few options on there. And Alexis, since you're seeing them come in, you can let me know when you think we've got sufficient answers.
Yeah, thanks so much, Jill. We have a lot of answers flowing in right now. Approximately 70% of all of our participants have provided a response. And so I'll give it just a few more seconds. All right here. So I will go ahead and share our results.
All right. Well, we're dealing with a crowd that knew the answer. It is all of the above. So if you picked any of the rest of them, you were also correct. So community supports, and we can go to the next slide. Community supports providers are not limited here. It can include community-based organizations, social service agencies, and many other types of entities, including counties, but no limitations. Anyone who can meet the requirements can be considered for contracting for community supports. If you feel like you have expertise in this, in one of the community supports that you're interested in, and it has not aligned well to the requirements of being a Medi-Cal provider in the past, this is an opportunity to take another look. And the other major consideration would be to look to see if the managed care plan or plans in your county have opted to provide those community supports in your area and when. So there, as I mentioned earlier, there's a phased approach. Many community supports are live in many different counties. Others may become live in July or in next January. So there's a real different schedule county by county. Next slide. So briefly, a look at the role of community supports providers. Community supports providers must have expertise within the community and specific experience on the support they're contracted to offer. They're going to deliver critical medical and social services. They must contract with managed care plans and become part of that network of providers. We expect this to expand managed care plan networks to include CBOs who have not previously been engaged in contracts with managed care plans in the past. And as providers within the Medi-Cal system, community supports providers must meet contractual requirements, including those related to models of care, billing, data sharing, et cetera. And we'll cover a lot more of that, those weeds in future presentations. Next slide. So we'll talk briefly about some of the pathways to becoming a community supports provider. Next slide. There are two primary ways to get involved in this program. Option one, and this is the main pathway to becoming, to entering this program, is to contract directly with the managed care plan or plans in the county in which you operate. A less common but equally valid option would be to contract with a county or other entity like an FQHC that has an existing contract with a managed care plan and is going to act as an administrative hub for those community supports providers. We'll go into a little more detail about that in a future slide. The next slide. So this direct contracting option, again, the most common one, involves reaching out to a managed care plan in your region. The managed care plan will go through some sort of application process with the prospective provider that will look at whether they meet the criteria to deliver the actual service, whether they meet capacity requirements, they have the data sharing infrastructure to actually exchange reports, the ability to bill or submit invoices, and the ability to capture and then reporting requirements required by the state. MCPs all have a process for demonstrating readiness and for contracting for community supports, and will often work with providers to address any gaps that come up in that assessment and readiness process. Next slide. All right, so this less common option of contracting with another entity, becoming a subcontractor, these relationships often stem from existing relationships, either developed under whole person care or other pre-existing relationships between an FQ and, say, a homeless service provider. Subcontracted CBOs have to meet all of the same service requirements that the contracted entity has to, but that prime entity that has the direct relationship with the MCP may be able to take on some of the administrative functions. Oh, thank you, Carlina. My apologies. And that might include things like data sharing, reporting, invoicing, billing, to sort of ease the burden on the CBOs they're subcontracted with. Next slide. So now I know there was a question in the chat about funding sources. You set us up perfectly. I'm going to hand it back to Lucy to talk a little bit about potential funding sources.
Great, thanks, Jill. Next slide. So there are a few potential funding sources to help folks implement community supports, and they're targeted to different entities. And so I just want to walk through what those are. The first is the incentive payment program. I want to say right off the bat that this is targeted to managed care plans. Managed care plans will be the ones directly getting and receiving these funds from the state. But there is potential for them to trickle down to community providers. So I just wanted to say that out front to avoid confusion. So this is a large funding stream. It's $600 million in payments to managed care plans in this fiscal year, 2022, 2023, and an additional $600 million in 2023, 2024. The goal of these funds is to make the enhanced care management and community supports successful. That's to make it possible for health plans to help community providers build capacity, build sustainable capacity at that, really look at the delivery structure, system infrastructure, bridge silos across physical and behavioral health, reduce health disparities, and improve quality of care, and really incentivizing the managed care plans in the first place to take up those optional community supports. As Jill noted, they're optional. So this funding is really meant to be a carrot for health plans to say, hey, there's value in taking these up. Please consider it. So that's the first step. Next slide, please. So as I said, the funding is for managed care plans. The way managed care plans earn this funding is for meeting milestones in delivery system infrastructure, provider capacity building for ECM, and community supports, provider capacity and take-up, and quality. So once a managed care plan receives funding, they can spend those funds as they see fit. And one of those ways is by trickling that funding down to their community providers. So community providers are able to build infrastructure, build capacity, improve quality, which only helps the managed care plans meet the requirements of getting this funding in the first place. So there's two payments. The first payment went out and it's tied to reporting and is subject to recoupment if the health plan isn't able to meet the requirements that based off their reporting. And payment 2 is tied to meeting the metric targets. Next slide, please. This is just a little timeline of where we are. So to request the funding, MCPs needed to submit a needs assessment and gap filling plan way back in December 2021. And that plan really acted as the baseline for the milestones that they'll later have to meet to continue to receive funds in 2023, 2024. As I said, MCP already have their initial payment. They received it in February, but they have to report progress on meeting the milestones coming up this spring. So existing community supports providers that are already contracted with MCPs can access IPP funds based off of agreements with their managed care plans currently. All right, the second funding, if we want to switch slides, is the PATH program, if you hear people talk about it. PATH is providing access and transforming health. This is another funding source, and unlike IPP, PATH funds are directly for contracted ECM and community supports providers. So for those of you who are contemplating becoming a provider, this funding would be available once you have that signed contract with your health plan. It's a 5-year, $1.85 billion initiative. So it's a huge amount of money that's really also meant to make this program successful, to build up the capacity and infrastructure of CBOs, public hospitals, counties, tribes, and others to successfully participate as ECM and community supports providers. It's meant to address gaps in local organizational capacity and infrastructure and enable capacity building. So it's definitely meant for the community, and I really encourage you all to check the PATH website. I think I'll drop a link in a little bit for updates, but next slide. So as I said, PATH funds are for you at the community level. Providers will need to apply for PATH funds to maintain and build capacity for ECM and community supports. I can't say a whole lot more about the application process yet. The applications have not been released. So if you're hearing about it now, you're not already behind. This is a funding mechanism that is still yet to be released for the most part. There are 4 PATH programs, but I'm really going to focus on those that are relevant to you as community providers today. There is a whole person care services and transitions to managed care mitigation. This is for counties that participated in whole person care who needed help in, maintaining services while the health plan takes up community support. So this is not going to be relevant to most folks, and the time has already passed for this. The 3 components that are relevant to you are PATH program for technical assistance, for collaborative planning and implementation, and for capacity and infrastructure transition, expansion, and development. So this is what's coming up, and these are the components that the application has yet to be released, but should be in the coming months. And so I encourage you to continue to check the DHCS webpage to see when that comes up. And I think I talk about that in the next slide as well. So yeah, as I said, continue to check back DHCS for the application process. And if you're on the edge and trying to decide if you become a community supports provider, know that if you do become a contracted community supports provider with your health plan, these funds would be available to you to increase your capacity and grow your infrastructure. So I will pause there to see if there's any questions on IPP or PATH or anything else we discussed today before we move on to takeaways. All right. So I just maybe we go to the next slide and review our takeaways. So we wanted to really leave you with a few things today, and that is that Medi-Cal is California's Medicaid program, and that's what we're talking about when we talk about CalAIM. CalAIM is addressing California's Medi-Cal program. It's specific to the Medi-Cal program, which is a multi-year initiative that DHCS is undertaking to improve the quality of care Californians who have Medi-Cal receive. And it's so innovative, as Jill noted. States around the country are looking to California to see how this, how CalAIM initiative is implemented, what the takeaways are, what the results are. So it's a big deal. Community supports are just one piece of that larger CalAIM puzzle that's really focused on bringing the community providers in to treat Medi-Cal beneficiaries as a whole person and connect them to these important services in lieu of being in the emergency room, et cetera. So as CBOs that have expertise in the services community supports cover, can contract with managed care plans or potentially through another entity such as your county and FAQ, for example, to become providers and be, formally part of the Medi-Cal provider system and network. And IPP and PATH are funding mechanisms that are available in one way or another to help you build your capacity, to build your ability to really be a Medi-Cal provider and provide community supports to the folks in your community. So those, we hope you walk away from this presentation with those items in mind. And with that, I think we'll go to questions, Alexis.
And
Yes.
I can jump in. We've had a couple good questions come through the chat.
Awesome, Jill. Thank you so much.
The first was, what's the total population to be served? So it is not restricted. Both enhanced care management and community supports are, if first of all Medi-Cal beneficiaries are eligible if they meet criteria under enhanced care management and their population is live within their county. So a lot of caveats there, but it is a benefit. And the estimates are that somewhere around 1% of the Medi-Cal population will be eligible. So 1% of that 14 million that Lucy mentioned, but it's not restricted. Community supports also does not have sort of quotas or caps. Folks who are eligible and for whom the service is live within their county can receive the services. So not a super helpful answer. I don't have numbers for you. I think we're waiting to see how many folks actually get enrolled in these programs statewide. And there's another question around whether CBOs have to apply to become community supports providers before becoming eligible for PATH funding. A concern that not sure organizations without appropriate capacity in place would be approved without the needed PATH funding improvements. It's a great point. You do actually have to be contracted to apply for the funding, but the funding is there to kind of help ramp up. A lot of plans can be flexible in terms of go live dates. So something to consider, there could be a contract in place even if you're not live yet, or a ramp up provision in place. So there is some flexibility there.
Yeah, and going off what Jill said, our sessions 2 and 3 of this series will really dive into what you need to prepare when you're looking to become a contracted provider with your plan. a readiness assessment, et cetera, and what the plans will be looking for in terms of, when you submit that readiness assessment, if there's gaps, how what you need to think about working with your plan to fill those gaps. So that's more to come in our future sessions. I just wanted to put a plug in there.
And I see that Beth has her hand up. Beth, definitely feel more than free to unmute to, engage with this conversation, ask any questions that you may have.
Oh, I'm sorry. I just realized that I came in as Beth, but my name is Lillian Marino. I work with Redwood Community Health Coalition. It's a consortium of health centers. One of the things that we're running into with ECM is the outreach that we have to do to the patient for the patients. Is there conversations around how CBOs can support those who are ECM providers? Outreach, and then how could we contract with them to help us with, can we divide some of the money to contract with the CBOs that cannot be ECM providers? Kind of like share the wealth, since they're really the ones that know the individuals on the ground.
Yeah, it's a great question. And it would depend on conversations with the managed care plan. There are plans that have provisions that require approval for any subcontracts. So you'd want to check the contract for that. But it's not uncommon to see subcontracted arrangements between ECM providers and community supports providers. I think that happens for kind of two big reasons. One, sometimes the ECM provider doesn't have the expertise or the capacity to provide the community support. So let's say you're an FQHC for a health center, and you're really great at the care coordination, at the care management, at the medical care management, but you don't have housing navigation on site. That would be a great opportunity to partner and subcontract with a homeless service provider in the community who does have that expertise, and there would be sharing of funds. There are other cases where I think more of what you're talking about is there just isn't capacity at the CBO level to provide a basic function like outreach, like billing, reporting, data capture, that kind of thing. And so a larger entity comes in and provides support for that smaller entity so they can still participate. But again, I think in terms of whether it's allowed or not, it's certainly allowed by the state. The question is it allowed by the managed care plan in your community that you're contracted with? But we are seeing a lot of those arrangements pop up.
Thank you.
Fantastic. Thank you so incredibly much, Jill and Lucy. And just to follow up on the questions that we've been receiving, I think that we just received another one. Jill, would you like to go ahead and read and address that one, the last one that we just received?
So the question is, can private companies participate as a contractor in providing care management and contract for other on-the-ground services? So the answer is yes. It depends on the private company. Are they a private for-profit care management, telephonic-based care management entity? They're allowed to participate. And in some regions, those types of organizations are filling the gaps where there just aren't on-the-ground providers. That said, it's certainly the intention of DHCS, and there's a lot of pressure on health plans to contract with local organizations who know the community and who can provide in-person services. That is the intention of both programs, enhanced care management and community supports. So it's a yes, but it's not the intended model. It's a great question.
Thank you so much, Jill. And so I did want to give everyone or encourage everyone, we do have time left, so you can feel more than free to unmute to ask additional questions or to just simply drop those questions in the chat. And just following up on some of the poll information that we received earlier, we did see that approximately half of the audience was only somewhat familiar or unfamiliar with Medi-Cal, and that information is highly reflective of what we learned during our first phase of work. During the first phase of work, we realized that yes, there were some small some CBOs that were further along in the contracting process, while others were very much so, very new to CalAIM, still had questions, still trying to figure out exactly, how community supports fit into the context of managed care in CalAIM. And so based on the information that was shared today, specifically for those CBOs that, were only somewhat or, just vaguely familiar with Medi-Cal, I just wanted to go back and just ask, like, based on any of the content that was shared today, are there any questions pertaining to, IPP or PATH, any questions pertaining to direct contracting or indirect contracting, the types of contracting entities that could potentially serve as those conduits to securing contracts, any questions that you may have like that. This is definitely a great opportunity to ask, because like I said, we, are just seeing a really great correlation between those CBOs that do not have all of the familiarity and what we learned during the past phase of work, with some CBOs just being at that very early entry level of trying to secure or work towards those contracts. So just wanted to open up the floor again. And I do see another question that's coming in right now. And it's, yeah, Joe, would you like to?
It's such a great question. So medically tailored meals, medically supportive food is actually kind of the best example of a community support that's already fairly well integrated into a lot of the managed care plans. So a lot of managed care plans a few years ago in California sort of figured out that this was a very low cost service to provide and had very obviously cost saving. A lot of this was demonstrated through a pilot that the state ran and is still running, that was very successful, to provide medically tailored meals in several regions. So yes, we can definitely get you the names of some of the contracted folks, but currently almost all of the health plans are offering medically tailored meals as a community support statewide. Some of which are, some of the contracted providers are local CBOs. One that comes to mind is Project Angel Food in Los Angeles, Project Open Hand in in the Bay Area region. And then there are some other larger national organizations like Mom's Meals that are providing it statewide. But yeah, it's a great one to look into. Yeah, and Carlina shared the California Food is Medicine Coalition. They're really remarkable. They include a lot of the organizations I just mentioned, and were a big part of getting that pilot off the ground a few years ago. Yeah, and the question is around smaller food providers who have a big learning curve. Yeah, so I think we'd point you to the Food is Medicine Coalition is a great place to start. It includes a lot of those smaller organizations, including Project Angel Food and Project Open Hand. And they are several of them are successfully contracted with managed care plans and billing, submitting claims. I will also point out that, and this is getting into the weeds, we said we wouldn't get into until a future presentation, but managed care plans are required to accept invoices if there's an organization that can't submit claims yet. The invoices are standardized statewide. They are fairly involved, and they include a lot of the same information you'd have to put on a claim anyway, but it's a way to get around submitting claims in the short term while you build that claiming capacity.
And I see that we do have a question from Patricia. Patricia,
I have a question.
Unmute.
Yes, I was wondering if you could share with us a little bit the experience that was demonstrated with the 4 counties. I know it was mentioned last year at the end of the year or beginning this year, you all worked with Shasta and a few other counties. And were there any best practices or anything that you can share?
Yeah, and so based off of some of the learnings that we took away from the first phase of work, one of the biggest takeaways that we had most definitely was the fact that the CBOs themselves are just grossly varying levels of contracting readiness, right? And so what we learned was that to move the needle and getting those smaller CBOs more prepared was that there was more TA that was going to be needed. So within the first series of sessions, it wasn't going to just take 1 or 2 sessions to get the CBOs, at the level of readiness and to build up that knowledge base and to build up those relationships to be able to move them immediately into contracting. And that's exactly why we're going to host these sessions for the next 6 months to make sure that those CBOs, that don't currently have those relationships are up to speed. And that gives me another flag that on the website, we're also going to provide a little bit of information that shows some high level overview and like a summary of like results that we received from the previous phase of work. That explains, why we are where we are in this process and how this is going to help those CBOs get to a place or, get closer to a place of contracting readiness.
Was there any type of work plan or anything developed that could be shared in that sense, like a social enterprise plan, some type of framework that can be passed along to different nonprofits to use or see as an example of a model for a program?
I don't believe right now at this moment that I do have a framework that would be similar to that, but I would definitely love to be able to just do a little bit more research to see if that's something that any of the plans themselves have been working on, and I would definitely be able to pass that along. I know one of the things that we've been discussing with a few of the plans is potentially being able to complete templates that we would then be able to pass on to community-based organizations to give them a better understanding of how to fill out certain reporting forms, certain contract portions, things of that nature. But it's not something that's been finalized just yet, but I can definitely follow up, after the session to see if there's anything that I might be able to pass on that's relevant.
Yeah, I'm with Monterey County, and I really think that's what our CBOs may need. And they don't know what to ask at this point. So even giving them something, not a business, but a program model as an example would be very helpful.
And I would also mention on the DHCS website, and we can drop the link in the chat. There are provider guides that are specifically for CBOs and other providers that don't have contracting experience to kind of walk them through. It's not a work plan per se, but it's by area to kind of walk them through the requirements of the program. And it's a little less heavy on guidance, on technical guidance than some of the other documents up there. The other thing I'd mention, I think Monterey is Central California Alliance for Health is the plan there. And they very likely would have a readiness document, some kind of tool that CBOs could use as almost like a checklist to even see if they could meet requirements. And then that same tool would be used to apply to be in the program with the health plan. So that's something you could request. There are Central California Alliance for Health isn't in this group, but there are a lot of health plans statewide who are using the exact same tool. So even looking at that would give you a good sense of what's required.
Okay, perfect.
Perfect. And I do see that we have another hand up. You can definitely feel more than free to unmute to ask your questions.
Is there a rollout schedule of when counties are going to take on ECM or consumer supports?
Yeah, we can share that as well. It started with the counties that had already done health homes and whole person care. They went first. And then it's sort of by population more than it is by county. And that's actually somewhat in flux still. But yeah, we can share what's been published.
And so before we go to the next question, I just wanted to let everyone know that I did post the copy of this presentation's link inside of the chat, and I'll go ahead and reshare that right now. And so all of the links and references, including that guidance that Jill previously touched base on, is going to be in the appendix of this slide deck, so that way you can have instant access to all of those resources. And I do see that Ileana, I believe that we have another question from Ileana, yeah.
Yeah, I'm wondering if there's any standardization for counties in doing like a landscape analysis of potential providers. And will you be collecting any innovative strategies that the counties are doing and working with CBOs and providers. Just wondering what is being done. I'm seeing different counties do different things. So that's my question.
I'm not sure. I'm so sorry. I'm not sure I totally understand that question. You're looking for a landscape.
Yeah. Are there any counties that are looking at like what are the ways that they are engaging providers?
And are you specifically talking about like county entities?
Or yeah, like the managed care providers?
Okay. So yeah, it's a really interesting question. You know, how do we know kind of what's happening statewide, county by county? You know, to our knowledge, there isn't an effort to sort of catalog exactly which CBOs are contracted by managed care plans. Managed care plans themselves have to submit their networks to DHCS. So DHCS has an idea of who's being brought in county by county, but it's not that those are not made publicly available. The other thing I'll mention, and I think Lucy already dropped it into the chat, is there is on the DHCS website a look at what plans have elected to provide county by county and when regarding community supports. So that's one way to know kind of like who's doing what where, but it doesn't give you a look at which providers are contracted for that. Unfortunately, that's not public.
Jill, this is Rishi here. Just to build, can I just ask a clarifying question to that? And hi, everybody. Rishi Manchanda with HealthBegins. Really appreciate all the questions. I'm wondering, Jill, if you think that, and for everybody, if you know, as the PATH TPA gets announced and the infrastructure comes online, if we think collectively that might afford more insight at some point in the next several months, or at some point this year, right, about information about who's doing what in which counties as well. I think I'm imagining there's some hope there that the infrastructure coming through the PATH funds and the TPA specifically might be able to provide more insight at a statewide level to the question that was just asked.
It's a really good question. I think there's so much we don't know yet about how the TPA is going to operate and what they'll make public, but it would certainly be of value if that's something they're able to kind of publish.
Mm-hmm. Yeah, thank you.
Yeah, that's where we are in our county as well. Really not knowing the landscape, and there are a lot of potential nonprofits that we would like to bring on board, but we don't have the information because the Alliance, again, as you mentioned, Central Coast Alliance, they may not be ready to onboard so many CBOs at the same time. So for instance, the justice involved, there are several organizations in the area that, because I'm with the county, I would like to, prep for the upcoming activities and opportunities for them. Although the other departments like DSS and even the sheriffs and going into the jails, they're not ready yet. So it's been a difficult. It's been difficult to time it out and to bring people. I don't want to overwhelm people with the Medi-Cal billing and discourage them too early on.
Yeah, I mean, so one thing I'll say is you're not alone. I think a lot of counties are really struggling with how do we make sure we're taking advantage of all of these new opportunities that are coming down the pike under CalAIM, while also meeting all of the 5 million requirements that are also coming down on counties under CalAIM, especially on the behavioral health SUD side. So you're not alone. I think billing is incredibly daunting for a lot of different types of entities, counties included. Although there are, like I said, there are workarounds, including invoicing that might be available. I'll also mention, the justice involved population is not live under ECM quite yet, so there's still time. And the, more globally, health plans can opt into new community supports every 6 months. They're expected to continue to build their networks over time. So I also, wouldn't feel beholden to one launch date, right? There are going to be opportunities to build capacity over time, to do phased launches, to do soft launches, or to just wait until you're actually ready to join a network.
I just feel like maybe the path funding opportunity might come and open quickly, and we're not prepared to just put that application in. So it's kind of anticipating, knowing that the funding will come, and not really knowing how to get ready for it.
Yeah, so I want to validate that waiting has its costs.
Yes.
Yes, and path is a big part of that. IPP's, not going to be around forever. So yeah, I hear you.
Is there a range for planning purposes? Is there a range of per patient, rates that MCPs will get and be able to downstream to CBOs?
Yeah, so the ECM rates are not public, but all of the plans have their rates, and we'll share them privately. On the community support side, there is non-binding guidance that the state released that we can link to as well. That will give you at least a back of the envelope of what might be available through plans, but plans in both programs, plans create their own rates and rate structures. So there are some plans that have a per member per month for ECM. There are other plans that are paying fee for service, for instance.
Gotcha.
So different payment models, different rates.
I also see that Kathleen has her hand up, so I would love to be able to get to her question as well.
Thank you, Alexis. Can you hear me okay?
Yes, we can. Thank you.
Great. So I had a couple of questions from kind of a higher level, stepping back. I was unable to be on the beginning of the call, but I just checked through some of the PowerPoints. But in the original email that was sent out regarding this resource, it said, this is a new program and resource to aid community-based organizations. And I'm curious if this is the technical assistance, these webinars, or if there's other technical assistance, and like what that constitutes, this new resource, and or if there's funding attached with the work that HealthBegins is doing, or is it primarily that it's pointing us to some of the resources like PATH, educating us. So I want to just get my arms around the scope of technical assistance under this HealthBegins work. The second question I had related to that is, in some of your documentation, it mentioned delivering statewide and county-specific technical assistance across 7 California counties. I'm wondering which of those counties are included and what resources are only available to those counties versus the whole state. I know that was like probably 4 questions in one.
No, you're actually totally fine. And so the response to both of those questions is actually, it's linear. So that was fantastic. They were definitely correlated. So far as the resources that will be provided as a part of this program, there are going to be those 2 tracks of technical assistance. So track number 1 is going to be the statewide foundational information that we're covering today, which is going to include more universal information that CBO statewide would be able to use that's applicable to them despite the county that they exist in. And track 2 is going to be the advanced technical assistance that is going to be very county specific. And so we actually just published an information session that was able to provide the specific details regarding the differentiations between those tracks, the menu of topics that will be covered in the statewide versus the county specific sessions. That was also in an email that all of the registrants should have received. And I can definitely make sure that I post that link inside of this chat as well. And then I definitely want to invite Rishi Manchanda, our CEO, to see if there's anything else he would like to add on to that. But so far as the resources that CBOs are being provided, that information session also includes, high-level coverage of the value propositions that are that address being able to participate, in this TA. Because building upon the lessons that we learned from the first phase of work, we realized that the CBOs that were at a lesser capacity or a lesser level of readiness to move forward with contracting did not yet have the knowledge, skills, resources, and relationships that they need in order to move forward in that process. And so one of the key differentiators between the statewide sessions and the county specific sessions is that in those county sessions, we do have the plans themselves present. So whatever questions that the CBOs have pertaining to contracting, they're going to get those on the spot responses that are specific to the county that they provide services in. So that's like one of the best, takeaways that we had from the first phase of work that supported the CBOs and being able to have a greater level of understanding of what the requirements are. And so, as I mentioned previously, the first phase of work, we held those sessions in San Joaquin, Stanislaus, Shasta, and Sonoma. And thus far, we're still, finalizing this, but we are going to be hosting TA sessions in the rural north and in Central California. And once we have those counties completely finalized, we'll go ahead and publish those on the website. So that way, CBOs that are in those counties can know exactly when they can sign up for those sessions. And they'll be able to participate in a CBO Readiness Assessment. And so that assessment is going to let us know, it'll take about 15 minutes to complete, but it'll let us know where CBOs are right now in the process, at what level of readiness they are, what types of support that they need. So that way we can make sure that the curriculum in the advanced sessions is catered to the responses and the feedback that we receive in those readiness assessments. And you can definitely feel more than free to ask see if you have any follow-up questions to that. And I definitely love to invite Rishi or Sadhana to provide any additional feedback that they might want to add to that as well.
I think you covered it really wonderfully, Alexis. Thank you. I think the only thing I just added, just to kind of recap at the high level, Kathleen, as you asked, is so this TA is supported by California Healthcare Foundation support. It's done in partnership, as Alexis laid out really beautifully, with managed care plan partners. The two tracks, these statewide sessions, which Aurrera is spearheading so wonderfully, are going to continue through statewide sessions to really be able to provide some support and information to a broad audience of stakeholders, including CBOs. And then the county-based sessions are going to be in the 7 counties. And more information, I think, will be available as we continue to update the CalAIM, the HealthBegins /CalAIM website. So we can put that link in the chat again, so you can learn more information about the specific counties that you'd asked about, that Alexis mentioned as well as the plan partners and the ongoing TA sessions and those networking sessions that will take place at the county-based level. There's a lot of great information that Alexis, you just gave in terms of the details about how those county sessions will be structured. But again, just encourage people, insofar as we're talking about this information session, just know that the county-based sessions in those 7 counties, we'll do a deeper dive, and more information about those will be updated as we go on the microsite. Thanks.
Quick question. For those counties that have multiple plans, are there consensus of whether those plans are going to have similar requirements, so that it doesn't become a burden on CBOs to have to manage 2 different contracts?
Jill, yeah, go ahead, please. Thank you.
So unfortunately, I think there is no envisioned endpoint where there are truly aligned contracts. The plans, I think, there were a lot of efforts both at the state level and at the plan level to try to coordinate where possible, to try to standardize certain policies and formats. But we are in a state now where things have been implemented and there are differences by plans. And that plays out in referral processes and billing processes and reporting processes. So yeah, I don't think there's a lot of effort to align more than they've been aligned, although I think there is continued collaboration between plans.
Thank you.
I will also mention there are some other efforts to kind of help consolidate the information so that CBOs aren't looking in 100 different places for what's Anthem's doing this week, and HealthNet's HealthNet has this due this week. So I think there are some efforts to try to get the information centralized, but yeah, it is a hardship.
Thank you so much, Jill. And I think I may have seen that we had another question from Sunil or from Ileana. I just wanted to make sure that we didn't skip over those.
None for me, thank you. Sunil here.
Awesome, thank you so much. And Ileana, did you have any additional questions? I'm so sorry, I thought I saw your hand raised, but I may have missed it.
No, I'm good, thank you.
Awesome, awesome. Well, before we move on to the last phase of this webinar, I definitely wanted to extend everyone else an opportunity to either post a question in the chat, raise your hand, unmute. Feel more than free to engage and let us know if you have any additional questions. And I definitely wanted to say that we appreciate the dialogue that we've had for, approximately the past 30 minutes. This has been very enlightening, very informative. Thank you for letting us know what your questions are so we can continue to track this, follow up with our plan partners and provide more information. And so definitely feel more than free to unmute and just dive in at any point. And in the meantime, I will also go ahead and move forward with just providing everyone with a little bit more information. And so if we go to the next slide, I would love to welcome everyone to participate in a very brief survey. And this survey is going to let us know, once again, just pull information from the participants themselves to help us better tailor, customize, and create these sessions. And so I've posted a link in the chat right now to a very brief post-event survey to help us make sure that these sessions are catered to your specific needs. And once again, as I previously stated, that we have a downloadable deck of this specific webinar that's also available in the chat. It will also get uploaded to our website, healthbegins.org/CalAIM, so that way you can have access to all of the hyperlinks that have been posted in the chat throughout this webinar. You can review that or use that deck to review all of those resources. And towards the end of this deck, something that we're not going to cover today is a very comprehensive appendix. It's also going to have definitions, more information on community supports. I'd love to thank all of our project partners for just investing a lot of tools, knowledge, and resources in that entire appendix. So that way we could have all of that information readily available for you. And then lastly, I'm going back to the questions that we had about those county specific sessions. Inside of that slide deck, there's also going to be that CBO Readiness Assessment that I discussed earlier. So that way, any CBOs that are interested in having that county level TA, you can go ahead and complete that assessment. So that way we can see exactly where you are within, your level of contracting readiness. So that way we can meet you where you are. And then I believe, if we don't have any additional questions for today, I just want to thank everyone for participating. This recording is going to be available on the CalAIM Links website, so you can definitely check back after this session to review it. If you have anything, oh, sorry, and I see that there is another question that we want to address.
Just one last thought.
Awesome.
Are there emails or contacts that we can get after this, just in case we had other questions along the way?
Absolutely. So as a part of this slide deck that I've dropped in the chat, you're going to see our email addresses, which is going to be calaim@healthbegins.org. And so that was also in the invitation that you received to this webinar. It's going to be on that website, that healthbegins.org/CalAIM, and it's going to be in this slide deck. I made sure to put in there a lot of times for exactly this. So that way you can reach out with any additional questions that you may have. And I also see that we have a question from Kathleen as well.
Hi, thank you so much, Alexis. My follow-up question, and your answer was so helpful and insightful, but I think my follow-up question, and it relates to some things a couple others have alluded to, is will there be any kind of repository of information, best practices, challenge successes, from across counties that maybe we can access to, and also I think about something like maybe a toolkit for moving forward in a various community support, for example, for the food, for the other, or for the billing, for the claiming. And then another part of that kind of relates to sort of some cross-county statewide sharing of information would be, is there a way that we can have access to the contacts, the people who are doing the similar work in different counties? So for example, I could learn in my county, what's happening with how things are progressing with the food area, the medically tailored meals in other counties. Like maybe somebody is way further ahead and I could learn from them, or how they got from, zero to implementing, such as, just some kind of way to stay in touch with people from other counties and learn, cross-sharing.
And Kathleen, can I ask you a quick question about which county you're in?
I am in San Francisco, city and county of San Francisco.
So like I said previously, we are just about ready to finalize the counties that we're going to include in our county specific TA, but I am happy to answer or state that the answer to your question essentially is yes. One of the things that's currently missing from our CalAIM website at the HealthBegins primary domain is a tab that's going to include project updates, project resources, networking opportunities, external TA opportunities. So in addition to the sessions that we are hosting, we are going to be working with various plans and other TA providers to amalgamate all of that information to have it in one centralized location. And in addition to having that on that project microsite that we've shared throughout the chat today, and it was also in the email that you received, we're going to include links to the CHCF website, and they also have, various resources that are available that can point you in the direction of those items as well. So the short answer is yes, but to the extent that you might be describing, I would love to learn more about that and collect information on that so I can receive more information from the CBOs themselves. And, we can discuss it with our project partners and with our plan partners, as to what the CBOs needs are, because going back to what we discussed at the onset of this call, that is the ultimate goal, is making sure that we understand what your needs are so that way we can figure out how to address it.
Well, I'll just also add, Alexis, to that, and Kathleen, to your question. I think you're also asking an important, broader question beyond the purview of what even remarkable sets of resources are going to be available on the microsite, right? There's a lot of information that that we're going to be collecting along with Aurrera Health and Transform Health and through the TA sessions across the counties we'll be working with, collating resources that we come across and putting them on the microsite, and as Alexis mentioned, to CHCF. But Kathleen, when I hear your question, I hear a broader kind of question and set of suggestions around toolkits, around kind of connecting TA partners and opportunities across the state. And so I will flag that I think what we are doing is necessary work to kind of address the needs that we see in front of us now. And also that in many ways, this is our hope for what infrastructure is going to be set up across the state, coming from the state, DHCS, the TPA, the third-party administrator for PATH funds, setting up the TA marketplace. These are the exact kinds of resources that we're hoping this work can inform and that we want to see statewide, because I want to make sure that while there's going to be a lot of incredible stuff that you're going to see through this project, there's also stuff that that this project can inform but not replace, that really has to be part of a statewide infrastructure. So again, I think a lot of our work is going to be trying to connect a lot of the partners and TA providers out there to identify those needs that we can address through this project, but also needs that we can't address through this project, but that others in the state should help address. Kathleen, does that help?
Yes, that is very helpful. Thanks so much for that. And I do have one other question, but I also don't want to monopolize the time if others have questions. Should I go for it?
No, you're totally fine. Thank you so much. We appreciate the questions.
Great. So I do have a question around justice involved populations. And, one challenge I'm seeing is this might be getting a little too into the weeds, and it might be more appropriate for a later call, that gets more in detail. But for jail populations, I'm still getting familiar with some of the work that I'm doing to support. I'm the community supports program manager for CalAIM implementation in San Francisco. And I'm still getting my arms around the justice involved population challenges and issues, but one that I understand is just for example, with some of those populations, the unpredictability of discharge from jail, and therefore the challenges in connecting people to community supports, or ECM services in a timely manner. And it might be something even just to pin for a future webinar, but I want to just throw that out there.
Yeah, I think it's a really important point, and there are a lot of not just community supports, but there are a lot of efforts around the justice involved population that will be coming down the pike over the next 6 months to a year. So I think it probably is beyond the scope of trying to answer the in the weeds on this call, but I do think it's a great question to ask. And I think there are kind of a few different ways DHCS is looking to address that particular issue, through policy, through pre-release Medi-Cal enrollment and other pre-release services, but I think much more to come, and I really appreciate you flagging it.
Thanks, that sounds great.
Awesome. Awesome. Thank you so incredibly much, Joe, for facilitating so many of those questions, and Lucy as well. Rishi, thank you so much. And so, and to all of the participants, we definitely want these questions to keep coming. So as I mentioned, the slide deck that was provided in this deck, and the email that everyone received does have the CalAIM email address or my personal email address. And you can please continue to send those questions in, so that way I can fill them as appropriately and make sure that we're getting you all the information that you need, as we continue to work through these sessions. And as I also previously mentioned, the information session is also available that will provide a high-level timeline of how we're going to execute these sessions. This is only the first of 2 additional statewide sessions to occur for a total of 3. And we want to make sure that within each one of those sessions, we're including the information that you need to be successful. And so with that being said, thank you all so incredibly much for joining us today. This was very exciting, very knowledgeable, very informative, and we are definitely looking forward to seeing you all at the next session.